Welcome, everyone. I'm Sarah Garber. I'm going to be the facilitator for this track. We'll get started in just a minute. I think we're ready for our first presentation.
We are presenting our interprofessional student-led mini-grant project titled Supporting Health with Harm Reduction Cumberland County Jail Wellness Bags. This project is an interprofessional collaboration between UNE Occupational Therapy, Public Health, Dental, and Medical students, the Center for Excellence in Collaborative Education staff, UNE faculty, and Cumberland County Jail, also known as CCJ staff. The aims of this project include creating 200 harm reduction kit bags to support the re-entry of residents departing CCJ, and 75 wellness bags for.
Some data that informs our project is estimated that 1 out of every 2 residents re-entering the community have mental health concerns, with 2 in 5 men and 3 in 5 women report having a combination of physical, mental, and substance use disorder. Within the first 2 weeks of re-entering the community, those with SUD are 120 times more likely to overdose than the general public. 2021 saw a surge of overdoses in Maine due to the rise in fentanyl, with 77% of the 632 confirmed overdoses being caused by fentanyl or fentanyl analogs.
The wellness bags include a range of supplies as seen on this slide, from toothbrushes, socks, notebooks, and bus passes to harm reduction items. The harm reduction items include Narcan, which can reverse an opioid overdose, fentanyl test strips to test substances for fentanyl contamination, and resource packets. The packets have locations and contact information for needle exchange programs, recovery centers, shelters, medical and dental care, employment opportunities, and helplines.
In order to pack these bags, we had a student-led event where we would meet with the corrections officers at the Cumberland County Jail, and we would pack these bags with them. Every bag is identical with the stuff that was in the previous slide. And then we also had an event where we would pack correctional officers' bags to promote their health and wellness.
Our future plans are to continue to strengthen relationships with the CCJ staff, to retain and update the resource packets and the mini grant information, and to follow up on how to improve the harm reduction kits with readmitted residents.
So funding for this project was provided by the Center for Excellence in Collaborative Education, also known as CC at UNE. And we also want to thank the Cumberland County Jail for allowing us to have this experience. And I have a list of people and organizations that donated to this project, and also a list of people that helped us and guided us through this project.
Thank you very much for an excellent presentation and a wonderful project. Are there any questions from the audience? If there are presenters from this team, please identify yourselves also. And I think Dr. Cohen Conrad has a question.
So thank you. And obviously I've been through this with you folks, but I'd love for you to talk a little bit about why you decided, because a lot of programs around the country do bags for people transitioning out of correctional facilities, but you really focused on correction officers. And so I'd love to hear a little bit about that decision and some of the input you've gotten about that.
I can start with that. So we kind of focused on both the correctional officers and the residents, like you said. And I think a big part of that was just because we wanted to get as much input from these correctional officers as possible. So meeting one-on-one with them and like allowing us to like facilitate those conversations and making it known like how important harm reduction is, handing out flyers. We've talked a lot about how the vision of like the correctional systems have changed so much. And so we learned a lot about that we learned a lot from them on how they've been able to change it and what they're going to change, and it can inform like our future in this mini grant in allowing us to continue the harm reduction kits.
Thank you so much. I think we have a question from Dr. Sheldon.
Yeah, good afternoon, everybody. My name is Mike Sheldon. I'm the Associate Provost for Academic Affairs here at UNE. I've learned a lot from my mentors, folks like Jan and Shelley over the years, that this engagement with community partners like the Cumberland County Jail really need to be sustained in order to be meaningful. It's like not just going in once and out and this never happens again. So Macy, I think in her remarks, talked about the future and hoping to strengthen further engagement. I have some experience from the past. I used to be director of the physical therapy program here, and we had some programming over there. So I'm really interested in your thoughts about the continuation of this program into future years, as well as any other thoughts you have about how else you might engage with the population over there.
So my name's Julia. I'm one of the other members of the Harm Reduction Kit project. We like twofold answer. One, we have applied for a United Way grant, and that would provide a much larger sum of funding than we get from the CECE office. So if we do get that, which we'll hear back from in about a month or two, that would be substantial and could definitely provide funding for several years. And then in the meantime, we're definitely looking to just continue with the CECE grant. And that is something that we continue to discuss of how we are going to continue these efforts, as it's not sustainable just to use the CECE money every year.
That's excellent. It's really exciting to hear about this type of a project, and the potential of continuing it for long term is really impressive. So thank you very much for your efforts and the support of the community and the interaction between you, the students, the institution, and the community. I think we've got about a minute before the next presentation starts. Are there any final questions? Oh, yes, Dr. Husband.
Hi, thank you. Such a fabulous project. I was wondering about the experience of actually sharing the kits, what that was like as a student team to have that experience of fulfilling the project and sharing the kits.
And if we could have a very short response to that.
We
Yeah.
didn't actually hand out the kits. We just filled them with the team, but we were able to hand out the correctional officer ones, and they were very happy that we were able to do that and like felt very appreciated, which we think will like transfer over to them handing out these harm reduction kits.
Thank you so much. And with that, we'll start transitioning over to our next presentation. Our next presentation is going to be from Impact of Leadership Roles in the Interprofessional Telehealth Approach to Long COVID Treatment by Kara Lattes.
Hi, everyone. My name is Lindsay Bollier. I'm a uni DPT student, and we're presenting today on the impact of leadership roles in an interprofessional team.
I'm Marissa Carbone. I am also a second-year DPT student at the University of New England.
My name is Caitlin Coates. I'm a first-year medical student at UNE.
My name is Karen Godney. I'm a master's social work student at University of New England.
And I'm Amber Haas. I'm a physician assistant student at Rosalind Franklin.
We did our experience with the Interprofessional Team Immersion program, and that was with Amanda and her husband, Mo. Amanda is struggling with long COVID. We met with her through telehealth, and as a team divided up interview time to each person to give an appropriate amount of time to get all the basic information. And the experience led us to want to look into leadership and how it's viewed and taught among different professions.
The leadership role of a physician assistant and a doctor of osteopathic medicine are often the first point of contact a patient has when there is a concern.
Both of these professions oversee the treatment plan and coordination of professional healthcare staff to ensure the patient is receiving the best care possible. They're also an important educational resource for patients, their families, and support staff during the diagnosis and treatment of every patient.
We're also the ambassador for these patients, which helps eliminate burden caused by balancing multiple specialties and visits.
Physical therapists are not often seen as leaders, and our leadership really varies depending on the setting. You can look at, we are referred as related service providers in the school setting, but we also have the ability to be direct access providers in other settings. It's important to realize that collaboration is emphasized to the highest regard because we rely on other healthcare professions to give us information, and they rely on us to give them information. Leadership is really important and is emphasized as a key competency in our program.
Social workers have historically not been in leadership positions, partly due to gender discrimination as well as distorted cultural values. There's little focus on leadership skills in school programs. In the NASW Code of Ethics, we're obligated to uphold and advance social work values. Social workers approach leadership from a systems perspective, hence the field lends itself easily to an interprofessional approach. The interplay of relationships is key, which is what we found during the simulation. Leadership roles are very important to establish when working as an interprofessional team, and they may differ depending on the patient. The most effective interprofessional team is one that understands each other's strengths and weaknesses and meets the patients where they're at.
Just to end, we wanted to quickly thank our faculty facilitators as well as our peer facilitator. Thank you for watching.
Thank you very much. That was an interesting presentation on leadership and interprofessional leadership. Are there any questions for the team, the Carolates? Dr. Jan Froelich, do you have a question?
Yeah, I was curious, how did the leadership play out on your team? You spoke about, how social workers and physical therapists aren't often in as much of a leadership role and some of the factors involved. How did it play out as you functioned as a team?
I can speak to this. So this is why we decided to do this as our presentation, because we actually had a really hard time finding somebody to be a leader on our team. Nobody really stepped up right away. And so we kind of floundered a little bit, and we were trying to figure out where we all fit in. And I think we didn't want to step on each other's toes. And so nobody came out as a leader right away. And so that was like an interesting dynamic with our group and why we decided to do this presentation.
Did a leader eventually emerge, or was it more of a collaborative process? Usually a group needs a leader. Sometimes that they're not even called the leader, but somebody's really got to kind of take charge and think about the whole. So what happened around that?
I can speak to that, Marissa, if you want me to. I really feel like it was really interesting in the interprofessional way that we all ended up being leaders in a way, and we all were just really listening to each other, and we gave respect to each other, to each our own professional expertise, and that each of us had a time to shine, and we really let each other step forward when the person was, when you're on, it's like, okay, it's your turn. It ended up flowing. We floundered and then it ended up flowing.
Sounds very organic.
Thank
And
you.
also-
I'm sorry, go ahead.
Oh, I also wanted to add on to what Karen said. I think the leadership roles changed once we got to know our patient Amanda and really understood what her specific needs were. So I feel like myself and Caitlin, who are more like medically knowledgeable, and that's like the basis of our education. We started off leading Amanda in her appointment, but then when we realized that she really needed more kind of like emotional support, that's when Karen became the leader, and then Marissa and Lindsay also helped and stepped up to provide a more of a holistic out view of how we could feel better.
Thank you. It's wonderful to hear how flexible you were.
Yes, it's fascinating, isn't it? The term I've heard for that is called fluid leadership. That the person in the profession steps up as needed and then hands off as needed. And it sounds like your team's experience was a perfect example of that.
What did you learn about one another that might have been most surprising about each other across professions? What kind of stood out, or didn't you know ahead of time?
I think for me personally, I really realized how powerful the role of the social worker can be in advocating for and helping the patient understand what their needs are and how they can have their community support them. So that was not something I had experienced prior, and I think it was really important to see that.
I really appreciated my fellow team members' being, really appreciated each other, I think. And we really understood what each other was doing eventually, and respected each other's roles. And I think that's super important.
Sounds like you all brought a bunch of humility to the team. Yeah.
That's exactly the word. That's the word I was looking for. Thank you.
And respect. Yeah. Thank you for sharing that. Just lovely to hear about your process.
I look forward to having you all as practitioners.
Yes.
Okay, thank you so much for that presentation and the humility with it. We're going to start moving to our next presentation. And this presentation is going to be Interprofessional Long COVID Migraine Management via Telehealth by the COVIDosaurs. Excuse me.
Newer complex conditions like long COVID have yet to be fully understood and often require thinking outside of the box. Our team of interprofessional students developed a plan that incorporated multiple disciplines to create a holistic approach for migraine management in a long COVID patient. Our team tackled the Interprofessional Team Immersion project, a telehealth clinical simulation experience.
Our student team consisted of Emily Blackwell from Occupational Therapy, Erin Kim from Allopathic Medicine, Dana Megan from Physical Therapy, Macy Punzlan from Dental Medicine, and Ashley Roy from the Physician Assistant Program. We would also like to acknowledge the support we received from Professor Denise Blaze, Professor Kristen Columbus, and social work student Sarah Kelly throughout this process.
The main challenge of this experience was to develop a comprehensive strategy that incorporated both pharmacologic and non-pharmacologic methods to meet the specific needs of Amanda, our telehealth patient, and her family. This is important as it teaches us how to collaborate between different professions and navigate patient-centered care through the added obstacle of telehealth.
In this simulation, we met Amanda Barry Mantell, who is a 39-year-old woman who suffers from long COVID. Our telehealth appointments focused on her chief complaints, her most prominent and debilitating one being incapacitating migraines. Amanda preferred non-pharmacological care, whereas her spouse, Mo, requested pharmacological options. Taking into account our patient and her family's priorities, we crafted a multidisciplinary approach to her care.
The suggestions our team came up with for the care of Amanda included pharmacology, relaxation strategies, osteopathic manipulation, nutritional counseling, and environmental modifications. These wide-ranging strategies allowed us to meet the complex needs of Amanda's diagnosis. Through this experience, we learned how effective interprofessional collaboration can be utilized to improve patients' quality of care. Thank you for listening to our presentation.
Thank you so much. Very interesting presentation. I'll get started. We heard in the last presentation about leadership, and I'm wondering, how did your team experience leadership? How is it handled within your group?
I can talk about that. So for our group, we kind of assigned one person as our point person that was going to be constant throughout every single session. So that way Amanda had a familiar face and like instantly someone that she already had a connection with. As dental students, PT, OT, medical, everyone came in. So Ashley was our PA student, so she kind of tackled that role. And then we all just kind of tried to collaborate around that while having her as our point person.
Dr. McCormick-Tutt, you have a question?
Yeah, great presentation, you guys. It sounded like you said her preferred treatment was not pharmaco. And yeah, that was one of your treatment options. How did you approach that with her to say, we know this isn't your preferred, but this is still one of the options we want to provide you?
I can also talk about that. So we tried to present her with pharmacological options that were much more on an as needed basis instead of a daily medication. So that way she felt like she had more control over if she was going to take them as not, just to give her as many options as possible to get some relief and be able to carry about her life better. So that was just the main goal, was to make her feel like she had as much agency in her own care, especially around medications.
And just a follow-up, did you get to do any follow-up with her after creating the treatment plan to see
what she decided to use and if it helped?
We did a little bit, but because of time constraints, we didn't get as much of that as we would have liked to.
Great. Thank you.
I have a question about what kind of environmental adaptations were recommended for the client.
Yeah, so from an OT perspective, I was looking a lot at her like environmental context and ways that we could adapt it to help her engage mostly at work. She complained a lot about headaches at work and just really struggling to get through the day. So we discussed just implementing breaks throughout the day and trying to advocate for her needs to her boss, which they discussed not always being the easiest thing to do. So we also thought that collaborating with social work could be a good idea to establish accommodations that could really help her advocate for her needs in the work setting. And I think if we were to go further, it would have been interesting to figure out how we could adapt her home environment as well. She did have like a calm space that she could go and take breaks in at home too. So I think just integrating that into her daily schedule could be really helpful.
And just as a follow-up, how about you mentioned relaxation, like what types of relaxation techniques seem to be the most effective for her?
Yeah, so we found a variety of options. We recommended different applications that she could use and also YouTube videos that were kind of specific to meditation for migraines, and just really try to find ones that were easy for her to access and use. In the first session, we recommended that, and then we followed up in the next session and asked if she had been able to try those out at all, and she had not. So we just made it more clear. We kind of developed a list and ways she could access those sites. So hopefully she would use them going forward.
Great adaptation.
Absolutely. Good sensitivity to the patient. Lots of empathy there. I wonder, with the telehealth format, did it help or hinder being able to sort of have some insight into her environment that you could actually see, or was the platform difficult to use? How did people feel about that?
For that, she was stationary, so we didn't really get to see around her environment. I do think if we had asked her to move around or show us her space, that might have been helpful. But again, we weren't as focused in the moment on her home environment, although that was something, like Emily said, that we would like to address in the future.
Since we have time, I'll ask the same question again. Was there anything you learned about one another that was surprising about each other's professions that you didn't have an understanding of before working together as a team?
On our team, we had a dental student, and I just didn't realize like how vast of knowledge that dental students, what their education consists of. Our dental student, Macy, focused a lot on improving the patient's diet and just they're focused on oral care. That was all super new to me, because when I think of a long COVID patient, I definitely don't, the first person I picture is definitely not a dentist, but your oral health really plays a huge role in your overall health. So I definitely learned a lot about dentistry.
Also on our team, we had two DO students, an MD and myself as a PA. So we had a lot of overlap as well. And I think it was really great to see how we all could contribute and take different aspects of the patient care. So I was really proud of how our team overall worked together and divide up the tasks and all have an important role.
Sounds like it was a really great experience. There are no more questions. I think we'll thank you so much for your presentation and move to the next one.
Nice seeing all of you.
And this next report is a collaborative case report on providing interprofessional holistic care by the Holistic Helpers.
Hi everyone, we are the Holistic Helpers, and today we're presenting a collaborative case report on providing interprofessional holistic care. Our patient is a 39-year-old female presenting with long COVID. She was hospitalized for 11 days in 2020-21 and her primary limitations include migraines and fatigue. Her health team is located 55 miles away from her home, which is an important detail to note. And in order to get back to her normal routine, she was interested in alternative approaches to medicine. And so we used the following care team members to provide a holistic approach to care. And here are Kleiman's 8 questions for cultural assessment, which provides us with a better understanding of what our patient is hoping to get out of her interventions.
So we decided to do some examples of a holistic care in medicine. We discussed with our patient acupuncture and medicinal medicines such as marijuana to reduce pain and frequency of her migraines.
We also discussed with our patient performing some lab tests to indicate if there's any deficiencies correlating with migraines in vitamins or minerals, and if so, supplementing them. We also discussed certain preventative practices, for example, having a more of a balanced diet, as well as suggesting blue light glasses, which can be preventative in helping prevent some of her symptoms and reducing the eye strain, sleep disturbances, and some of the fatigue that she has been experiencing. If those holistic approaches to medicine are not effective for the patient in general, we hope to do a combination therapy with migraine medications or place more of an emphasis on medications in general.
And to address her fatigue, there is research available to show that training twice daily using a threshold inspiratory trainer while maintaining diaphragmatic breathing improves peak oxygen consumption and quality of life, which offers an accessible physical therapy model with minimal resources to address her fatigue, and can also offer a great relaxation technique as well. We'll also use graded exercise exposure while monitoring her vitals. And to address migraines, we can perform manual therapy techniques as well as postural stabilization exercises.
For holistic care in occupational therapy, we can advocate for accommodations at her workplace to manage some of the fatigue she's experiencing, change some of her routines around to try and manage fatigue and maximize when she has the most energy. We can explore coping strategies to manage stress and anxiety, and there's many options for that, just depending on what she thinks is going to be most helpful for her. And we also want to push some participation in meaningful activity like hiking and gardening.
Holistic care through nutrition. We want to ensure total body wellness through access to a balanced diet, maintaining adequate hydration. This can be both towards total body wellness and her migraine prevention, taking a daily vitamin or any supplements depending on her deficiency. And then to address migraines, it's been proven that a reduction in sugar and a reduction in caffeine can both contribute to migraine management. We can also assist in a journal to start to narrow down some of her migraine triggers. So keeping a close diet recall journal when she's experiencing her migraines will help us pinpoint exactly where they're coming from her diet. Folate supplements is also a great beneficial to migraines. And then also taking a look at the gut-brain axis through probiotics, the way that the GI system can connect to the central nervous system. Here are some resources through social work that she may have access to and find beneficial, both through support groups and financial support.
And then some of the key takeaways that we've reflected on, and then we also gathered based on what the client gave us feedback on, was to build a lot of rapport and trust, to listen and hear their stories, recognize their symptoms are real and that they're not alone in this. We want to provide affirmation, offer her some more realistic hope, and applaud them for how far they've come, as well as come up with a solid plan.
Thank you so much for your presentation. Nice to see you all again. I was the facilitator for this team. I wanted to ask you, you had a really comprehensive way of looking, a very holistic way of looking at this patient and offering help to this patient. How did the leadership work? Did you feel like you had leadership, you need leadership, or was it fluid?
I can speak to that. I think we had a lot of fluid leadership, and the fact that we kind of went in each day and whoever took the lead was the leader. And I think maybe we might have benefited from a more structured leadership system than we had, but it did give a chance for everybody to kind of speak their mind and say what they were thinking, which was nice.
I have a question about some of the dietary recommendations. How did the client respond to those? Those can be very challenging changes to make.
I can speak for that. I'm the nutrition representative, but I actually was unable to make the second session. So in the first session, she was pretty closed off to any suggestions about changing diet and very adamant that what she was doing is perfectly fine. I think upon further follow-up, I would like to maybe like implement some changes or just better assess her reality, but we only had a small amount of time to work with the client. So I definitely think she could benefit from some follow-up care, but there were just other important factors to maybe entertain at the time.
Yeah. Thank you for sharing about the importance of that, taking on the nutrition related to migraines. As challenging as that is, and how much I'm sure you have to pull in a lot of motivational interviewing to make that happen for people.
I have a question. Your takeaways, the first one was to build rapport and trust. Within what groups? Is it between you as a care team or with each other, or the care team and the client, or both?
I can speak first if you'd like, but I think we were more between the care team and the client. I mean, amongst ourselves, we definitely established trust and respect and understanding, but I think it was really important. She was a little resistant to medical teams. So we actually had a social work representation who's not on a presentation, but we established early on that she was a great bridgeway in between the medical team and the patient, and the patient was very receptive to her. She was very energetic and warm and comforting. And so we used her a lot throughout our care plan and to introduce some certain things. So definitely reading the patient, understanding their wishes, and then formulating our plan as a result, I think were sort of what we meant by that.
Yeah, I think it's a really great learning experience for you in this case, that having all of these well-meaning people can be overwhelming. And so you sought an alternative, which I think is was smart of your group, to do that, to put the patient's needs first and identify that was overwhelming. So nice job.
Are there any lessons that you would take forward into your careers as you progress?
I think one thing I definitely am gonna take with me is just to really be clear on what the client's expecting of your sessions, because I think that was one thing that I struggled with, was not really knowing when to give her like a plan and when to keep like interviewing and getting more information and explaining options. So I think just making sure that both the client and the caregiver are clear on the expectations of what's going to be happening and what you're going to be giving them.
I think my biggest takeaway was one of the feedback comments she made to us was that it's okay to just say like I know what you're going through is hard, or just like acknowledging her symptoms more instead of being like, how are you doing today? Oh, well, we'll get you better. Like acknowledging that what she's going through is really difficult.
I have found for a lot of clients sometimes to even say, I can't even imagine what it's like, but I'd like to understand. For example, I wasn't raised in poverty. For people raised in poverty, help me understand, because that was not my experience. So, and people have appreciated it when you don't pretend that you understand what their situation is, but that you want to.
Any more thoughts or questions?
I just want to appreciate all the creative approaches, because migraines are such a hard thing in many people's lives. So it's just wonderful that you've taken this on, and the other teams as well, to really think about this important area.
It was a very tough case, I think, for most teams to approach.
There's a lot of hopelessness, I think, that you have to be very creative around, the hopelessness that's there for people.
I found too, on a piece of paper prior to meeting the client, we had this action plan that was one way. And then when we were with the client, we sort of had to pivot based off our response to some of our action plans. So as far as key takeaways, like we could formulate this massive plan, but then at the drop of a hat in response to the patient, that can completely change and be derailed. And the direction and emphasis is now placed on a different area of expertise. So I think that was a huge learning moment for all of us. And we were able to then read her enthusiasm for a particular field and then go with the flow that way and sort of lay off a bit on the recommendations in the other avenues.
That's great. And it was probably good that you had one another, right? Yeah, at those moments.
I think there was a lot of team empathy in working on that. Swapnika, you have a word?
Yeah, I was just going to echo what Hannah said regarding reading her patient and observing her body language, the way she opened up to certain professions and closed to others or closed to certain things, the feedback and things like that we provided. So I think that was really important to kind of support each other throughout the entire process and being able to kind of just read the room and understand like, okay, maybe she's not as interested in this approach. So we'll have someone else from our team to try to help her out to provide that most holistic care, like patient-centered approach that we were hoping for.
It's wonderful to hear everything that you did.
Hey, thank you so much. Great job.